While we were learning about these sky-high numbers, a 2-year analysis of how we prevent and treat HIV was just released. This research focuses on Saskatoon, but mirrors what we're seeing in communities right across the province. So to give us a snapshot of what we're seeing when it comes to HIV here, we have Dr. Cara Spence on the podcast today. She's assistant professor in the Department of Medicine at the University of Saskatchewan and is the lead researcher of this new analysis. Toby Esterby is Chief Operations Officer of the Westside Community Clinic. The clinic is on the front lines of HIV care in Saskatoon, and they have around 800 patients with HIV right now. Toby, welcome to the podcast.
Thank you.
Dr. Spence, welcome.
Thank you.
Toby, I want to start with you. 800 patients with HIV right now. How can that be?
Well, and that's the ones that we've seen that are active in the last year. The number of patients that we have that are currently diagnosed with HIV is even higher than that. Those are just the folks that we've seen in the last year. It's a unnecessary number. It's an extremely high number, but we have a small, not so small, army of folks doing the work to make sure that those folks are wrapped up in holistic care so that they can live a healthy life with their diagnosis.
Dr. Spence, what is the story here in Saskatchewan? What does the data tell us about what we're seeing in Saskatchewan?
Well, I've been following HIV data for over a decade now, and I've just seen some really sharp and stark changes over the last, I want to say 2020, but it was actually just prior to 2020, right around 2019, there was some changes in the social assistance program and the housing availability and affordability, and that really impacted this, the most vulnerable population, which HIV tends to hone in on. But the data is really showing us the changes in the epidemiology of this virus, and surprisingly and shockingly so. For a long time, it was, predominantly people who injected drugs, largely male, over 35 kind of demographic. But what happened in 2019, 2020 really shifted to primarily young women and heterosexual transmission. So, that change was shocking and astounding. And then also the rapid increases. Every quarter we see anywhere between 15 and 50 new diagnoses, which is really unheard of across the country and really even the world nowadays.
So you wanted to take stock of what we were seeing here in Saskatchewan. What did you learn?
So this came to, I was watching the data, in sort of shock and awe, but this work really came from the providers, the frontline providers that needed help to understand, what was happening, what could we do, what are some gaps, what are some duplications of services, and how can we move forward, how can we address some of the things that they were seeing. So what did I learn? Certainly the trends in data that I had been observing for some time. The tremendous amount of loss to follow-up, like Toby had spoken to, those that are just not engaged in care. Almost as many in care as not in care, which is again a real problem, given the amount of virus there in the community that's untreated. I also learned that just the lack of, or the non-coordination of services. There's lots of really great organizations doing some really great work, but not working together. And all of this, I would say, stems to the fact that there just isn't a plan. There's not a plan to address these increasing rates. There's not a plan to coordinate care locally or provincially, and that really creates a lot of gaps.
When was the last time we had a provincial plan?
Well, we had a provincial plan a number of years ago, and I think it kind of expired right around 2018. I think that's right, Toby. And it made a little bit of a dent or an impression in the data. There was a little bit of a dip, but it came right back up. And so since 2018, we really haven't had a plan, a strategy, or any sort of coordination.
No plan, and yet we're leading the country when it comes to new diagnoses. Toby, what do you see on a daily basis that helps illustrate some of the data that we've talked about so far here?
Well, at Westside, so there's multiple teams working out of Westside that interact with HIV patients at that frontline level, and there's a few different things that really illustrate the urgency and the seriousness of the situation that we're in. First of all, is just the number of new cases. The teams interact, like Cara said, like it's not that we're seeing a case a week; we're seeing several new cases every week, week after week after week. And that is a spread of infection that shouldn't be occurring, that it's completely unnecessary for that to occur if we had a plan and resources in place. The other thing that happens is that we really see at Westside the Venn diagram, as it were, of HIV care and poverty and proper primary health care. And if you don't look after one of those things, all three of those things come into play and really start getting affected. So we're really struggling, with folks that are trying to address HIV. They're trying to take care of themselves. They're trying to make it to their appointments. They're trying to do all of these things. But the social determinants of health that are affecting them are just so astoundingly crushing that they can't address their health needs. They need to worry about food security. They need to worry about housing. They need to worry about family relations. They need to worry about healing trauma. And after all of those things, then they may be ready to work on their HIV diagnosis. And in the midst of that, when we're seeing that the infection spread in community, those things are compounding the rate at which we see those infections occurring.
Dr. Spence, you started nodding your head when he mentioned poverty, and you said that it's women, and it's often being spread through heterosexual sex. Can you tell me more about that?
Well, that's a new trend, and that's a troubling trend. When it's heterosexual transmission, your risk factor is having sex, having unprotected sex, and that may be with a partner or a committed partner or otherwise. So. When you're looking at HIV is often related to poverty or social determinants, globally. We don't see these kind of trends globally anymore. HIV is a chronic disease now. It's easily managed, and there's excellent treatment available where you can live a long and healthy full life. But as Toby mentioned, when you're dealing with deeper core issues like housing and food security, your health often comes secondary, and it increases your vulnerabilities to looking for ways to find security, to find resources, to find money and funds. So without addressing these core root issues, then HIV in Saskatchewan, which is really quite embarrassing that we're seeing these kind of trends and rates.
Toby, do you find it embarrassing?
I really do. In the context of Saskatchewan, we are a wealthy province in a wealthy nation. We're a G7 country, and we hear often about how we are one of the more economically stable and prosperous provinces in the Dominion of Canada. And yet here we are leading the world in incident of HIV rates. Those two things shouldn't exist in the same place. We should have enough wealth in our province, in our communities, in our country to make sure that those who do not have can have their health care looked after. So yes, I find it extremely embarrassing. Number one, that we don't have a plan. And number two, that the folks that are trying desperately to do this work, if you ask any organization that works in HIV in the province right now, the first thing they will tell you is that they are under-resourced. So we need to address some really core issues before we'll even start to see this turnaround.
I'm sure there's a lot of people listening right now who are trying to wrap their heads around the fact that it is decreasing around the globe and not here.
Well, and not here, exactly. So these national trends, increasing trends, really, we're responsible for that here in the prairies. And having, gender is a social determinant of health. So with women, young women being adversely impacted, there's so many residual impacts of that with children and families and communities. So it's not just the woman that gets a diagnosis, the whole family and the whole community also feels the impact of that. So we really do have to go right to the root of this. The social determinants, having women as increasingly marginalized and vulnerable is, again, a target or a beacon for support that needs to be put in place.
We keep talking about, I've been talking about the rates of diagnoses, but how often are people dying in Saskatchewan of the virus? A lot of people know that this is a virus that can be treated, that people can live long and healthy lives with HIV, but is that the case?
So, I guess I need to back that up a little bit to make the answer make sense. So first of all, HIV is a completely treatable chronic disease. There's no reason to die of AIDS. There's no reason anymore. There is ample care. There's ample medicines. The science around HIV has advanced so much, and it's off of people's radar because out in public and those listening on the radio right now, some are probably surprised that this is still a thing. Yet here we are in the midst of what we characterize as an epidemic. So we have to back that up first and recognize that HIV care has progressed to the point that nobody has to die from HIV. Nobody should die from HIV. And then I'm going to tell you that we lose somebody every week.
Mm-hmm. Every single week.
I can give you the data on that. So we've had more deaths in this population the last 4 years than the previous 10 years combined. So the deaths that they're seeing frontline is, they can't even keep track. Every time I do these quarterly reports, that death number increases and increases.
How do you personally feel when you say that, Dr. Spence?
Oh, the moral despair frontline with the providers and even with those that are impacted is great, is really astounding. It's hard to work in this field and continue to work in the field knowing that these rates increase, that there doesn't seem to be a prioritization or an adequate resourcing to address, no plan. It just seems like we've accepted this as status quo, and it's not okay. This isn't acceptable. So it's very hard, and you see that moral distress across the whole scope of this work.
Toby, how do you process this?
Some days with a calm mind and some days with flat-out anger. When we see folks that we get to know on a first-name basis pass away unnecessarily, it's hard on the heart. And it's hard to justify working in a system that creates that death. And I want to be crystal clear in that, is that we should be able to build a system that creates the ability for people to remain well. But our lack of a system right now is creating structurally full-blown AIDS. HIV should not ever become full-blown AIDS anymore. There's medication. We were talking before, one of the most profound things that came out of the 2-year study, we were sitting in a meeting and one of the infectious disease doctors said to the room that she would choose an HIV diagnosis over a diabetes diagnosis any day of the week because it was much easier to manage HIV.
Is this just because of a lack of political will, Dr. Spence?
Yes.
Yeah?
Yeah, it's a lack of prioritization, political will, and resourcing. Really, there are solutions to this. There's global targets, 95. They used to be 90, 90, 90, and there are clear measures for those 90% markers. And they've actually increased to 95% of those that are living with the virus are aware of their diagnosis, are seeking treatment, and are suppressed. So, basically no active virus in their body, just, living a healthy, normal life. Those are real targets that are being met all over the world. And we're nowhere close in Saskatchewan. So you absolutely can, even nationally, you look at British Columbia, they're closing HIV/AIDS units because they've got their numbers, they're nearing those 95% targets. And what they did was just hammer it. That's what you need to do. You just need to put the resources and the prioritization in place, get the virus down, really get a handle of it, and then it's manageable. You can manage this virus.
What kind of resources are we talking about, Toby? What would be ideal at your clinic? What do people need who are working with folks who have have this virus?
Well, there's some on every level. The first notion is to make sure that we are treating HIV as a primary health care concern. So we need to resource it with clinical knowledge. We need to resource it with doctors that can prescribe the medication. But then we need to provide the supports around the folks that are accessing that care. So that looks like outreach teams. That looks like case management teams. That looks like supports to help folks navigate their journey with HIV. It looks like great pharmaceutical support that is connected to those primary healthcare teams. And it looks like a system of organizations that collaborate together to make sure that fewer and fewer people are lost to care. We recognize like HIV treated is no problem at all. You can live a full and healthy life unaffected, and with no virus in you at all, you are not infecting anyone. So you can lead a full and healthy life. But when folks are lost to care, they may be off of their medication, or they may be communicating that infection to others. So that's where we need to really work to make sure that we have fewer people that are lost to care. What we need for that is boots on the ground, people doing the work, many, many more people doing the work properly resourced so that those folks can have a connection to the care that they need throughout their journey with HIV.
And Dr. Spence, where do those resources need to be? I'm curious about the differences between, say, Saskatoon and Regina and how different the rates may be versus more rural communities in Saskatchewan.
Yeah, and we can't forget about Prince Albert and the north as well. So I agree with Toby, the boots on the ground, really dedicated care for people. And then to take one step further, it's the prevention of the virus. And that's the social determinants. We must adequately resource our social structures, our social systems. Housing is just a critical piece of so many connected and connected to so much in terms of health and those determinants of health, structural even determinants of health. So how to allocate resources? Well, we don't really even share data across jurisdictions, so or standard measures. So we need to really start with understanding what the rates look like in different communities and different urban centers. Really, it's a provincial scope. We have to ensure that housing is affordable and available. We need to ensure that resources are being allocated equitably. Even in Saskatoon, everyone just sends them to Westside. There's really not a plan or strategy. They just send them to Westside, and yet Westside Community Clinic doesn't receive HIV allocated funds from the government. So what we need to do is really look at where the highest rates are, like the increasing, where the gap of that care is, and resource it. So not only clinical care, but also these social determinants such as housing.
Can you tell me about some of the stories you've heard from people who are living with the virus? Like we heard from Starla off the top, and she shared a bit of what it was like to get that diagnosis and didn't feel cared for, in the hospital. What are some of the stories that stay with each of you? I'll start with you, Dr. Spence.
Oh, we did talk with people who were living with this HIV diagnosis, and it was really hard to hear their stories because Starla's story is common. Stigma is probably the biggest factor that prevents people from seeking care in the health system here in Saskatchewan. Westside has a tremendous team of really responsive and caring providers and individuals. Entering any healthcare system or structure or building is often very traumatizing for people because of the poor treatment that they've received. Getting that diagnosis, we have to be really kind and compassionate and supportive to give that diagnosis. It's not just something you throw out there on your way out the door, for sure not. Having peer support workers or people who also live with the diagnosis to be, part of that care team so that they really understand what that might feel like to receive that diagnosis. Just the fear and stigma that people live with is definitely a preventative factor from people seeking care.
Toby, what are some of the stories that have stood out to you?
What stands out for me with the stories is that there's both sides of it. There's some really there's there's some folks that have some really positive stories about, dealing with their diagnosis and working through that and finding that stability and then, becoming a leader in community, becoming a peer, becoming someone that folks can go to help with that navigation through HIV diagnosis and through starting your treatment and through starting care and meds and everything like that. And there's so many people that I've met along the way that are just inspiring in the way that they approach life with such simplicity and gratitude and grace in the face of a system that really isn't built for them to access care easily. They navigate it with such grace, and it's so inspiring. The flip side of that is, speaking to the social determinants of health and how important that is around the prevention piece, it shouldn't happen that a conversation occurs in our clinic where someone that we know well now also has added to their plate a new HIV diagnosis. But now that they have an HIV diagnosis, maybe we can get some more resources to help look after the social determinants of health. So the resources are after the diagnosis, where the prevention piece could have prevented the illness, could have prevented the infection. And that's just such a sorry comment on where we are resourcing the system. We are heavily resourcing emergency rooms, and we're heavily resourcing this reactionary care provision, where if we could just get upstream of that HIV diagnosis, we would literally wipe this out. You look at BC, you look at areas around the world where they've reached those 95 targets. HIV disappears. It can be a completely managed chronic disease. There's no reason that we can't get there.
And what exactly does that mean? The 90, 90, 90, the 95, 95, 95. What exactly does that mean?
Mm-hmm. So those are global targets set forward by the United Nations AIDS Commission. Been in play for, probably at least 20 years. And like I said, they used to be 95, 95, 95. And now we're doing so well globally. They've increased to 95, 95, 95. And like I mentioned, it means that 95% of people who are living with the virus are aware of their diagnosis. 95% of those are accessing treatment. And 95 of those are virally suppressed, meaning that they're living a completely healthy, normal life, and the virus is not active in their body, which means they can't spread it to other people.
For quite a few years, I thought the story in Saskatchewan was that HIV was spreading primarily through intravenous drug use. And obviously that story has changed. But I'm wondering what you would say to people who think, well, this doesn't affect me. This is about people living in poverty, possibly who have a substance use disorder. This isn't about me. What would you say to that individual?
So this is the problem with the current epidemic, that it's heterosexual transmission, any kind of sexual transmission. So if you're someone who is having sex, you are at risk. So it's not a poverty. You don't have to have be in poverty as a criteria. You don't have to inject drugs or do drugs as a criteria. It really is, now that it's moved into that level of risk factor, it really does affect everyone. And we have seen diagnoses of people who are just like you and I, who, for whatever reason has had, unprotected sex and now live with the diagnosis.
And is that just because, too, that the rates are just so high in Saskatchewan?
Exactly. There's so much virus in the community that it really affects everyone.
And I think the other piece there, it's HIV, it doesn't affect me. It does. I don't know anybody with HIV. First of all, they probably do know somebody with HIV. They just don't know that they do. And then the second piece, it doesn't affect me in Saskatchewan. Has anybody had any trouble accessing a doctor or had to wait at the emergency room? Has that happened to anybody? Because that's an impact. We have folks in the province that are accessing hospital beds and accessing the emergency room and accessing palliative care and accessing all of these things in the healthcare system that shouldn't have to access those things, because HIV care should be properly managed and you should never ever have to go to the hospital for your HIV care. So that's the impact. Like that's one of those system impacts that affects all of us. We all need to have a vested interest in making this better and making the system work better. It will have an impact throughout the system. It will have ripples of impact throughout the system, ripples of impact through generations. And that's maybe back to one of the biggest things that breaks our hearts these days is we're seeing young mums. You know, we need to get to those young mums in time with that HIV diagnosis so that we do not have a baby born with HIV. That should never, ever happen in this world.
But
anymore.
It is happening in this province, in this city. You know, some women are diagnosed with HIV in pregnancy because it's now part of the standard routine laboratory tests. But, you know, how long was she living with HIV before she had that standard test? So, you know, just young women or young women are particularly vulnerable to this virus, which really troubles me.
So what now? Now that you have this analysis, you have a clear picture of what HIV looks like in Saskatchewan or in Saskatoon, and then how that relates to other communities in the province. Now what? Like, what are you hoping this data reveals, and what is the call to action?
Well, first and foremost, thank you for having us, because it's drawing attention to, because this is, although our rates are you know, starting to chunk up again, this isn't a new story in Saskatchewan. So to have renewed attention to this issue, I hope will draw some political will and prioritization. We do have a really strong group that works well together, that I think, given the diversity of that group, can come up with some sort of plan to present to the government to say, hey, this is what we think. Part of that would be a provincial program where many people move through communities and centers, urban centers, and how many of those are lost to follow-up or getting care elsewhere, we don't know. So a provincial scope on this matter would be super helpful.
Yeah, I think like my hope for the what now is that I hope this study and these conversations and the continued conversations start to light that fire. You know, start to light that fire of awareness throughout the province, not just in our circles of folks that work with HIV, but start to light the fire of folks that are hearing this and saying, how is this still a thing? How is this happening in my province? We want to light that fire and get people talking and understanding HIV in its modern version. Stigma-free, completely manageable, absolutely just a chronic disease management piece, and living a full and healthy life. We need to light that fire so that people are having that conversation. And then we need to light the fire of the folks that are doing the work at the ground level too. There's, like we've both said, there's amazing teams in place, and everybody is burning
out.
Yeah, like it's so much work. It's so overwhelming. It is. I tell people often that some of our work is the most frustrating and rewarding work that I've ever experienced in my life, because you're constantly banging your head against the system, and then once in a while you get something that's like, oh, thank goodness we got that to work. So it's both things, and we need to light that fire in our teams to feel hope and to feel that we can come together as a larger group, something bigger than the sum of our parts, and actually get some momentum and get some drive and get some energy into the real changes that are going to fix this.
Toby, Dr. Spence, thank you so much for being with us today.
Thank you for having us.